All right, so like I was saying, I'm Jackson Hatfield, Family Medicine, work with Archibald Primary Care, and we get the opportunity to talk tonight about how obesity is linked to both hypertension as well as heart disease. So adult obesity, so I just wanted to take an opportunity to define, when we say obesity or overweight, what do we mean? So we use what's called a BMI, body mass index, and as you can see, normal range is between 18.5 and less than 25. We categorize patients as being overweight, excuse me, if their BMI is between 25 or less than 30. And then obese, when we hear that, that's pertains to those patients that have a BMI of greater than 30. And you can see it's calculated based on a weight versus a height. So it is a calculation that we use. It's also defined with waist circumference as well. So in males, obese patients have a waist circumference greater than 40 inches, and for females, it's greater than 35 inches. And as you, while we're here to talk about this, is because unfortunately, obesity is an epidemic in our society. So about a third of adults in America right now have a BMI of greater than 30. And when we talk about, the effects and the healthcare associated costs of that, in 2008 it was estimated that about $147 billion was spent on obesity and obesity-related illnesses, and that stems from high blood pressure to diabetes to even the cancers that we're going to talk about today. And we think this is going to be more costly going forward. So in 2018, it's expected that cost is going to be doubled. And again, that is not only to treat obesity, but also those medical problems that are related to that. When we look at obesity by different races as well, it affects all races, but definitely some to a greater degree. In our country, about 48% of non-Hispanic blacks are in the obese range. 42.5% of Hispanic patients fall into that obese range as well, and then about 35% of non-Hispanic whites as well. And unfortunately, there are certain areas of our country that are plagued with this more than others, and living in the Deep South, we are definitely guilty of that. So as you can see, the states that are in the darkest maroon or red color have a percentage of patients greater than 35% that have a BMI of greater than 30. You can see Georgia is between 30 and less than 35%. But it's definitely something that within our southern region, whether it be the foods that we eat, the diet, our lack of exercises, is contributing to our population having more obesity and, unfortunately, then the results of obesity as well. So when we think about just our state of Georgia, so about 30 to 31% of our adults in our state have a BMI of greater than 30. And we've see this is again broken down with different races as well. And we know this is not just a disease that is affecting adults, but we're seeing it more and more in young children. And unfortunately, when young children develop being overweight or obese, we find that they carry that into their adulthood as well. And with that, we're seeing more and more of the complications of obesity occurring early and earlier in teenagers, even younger kids. So again, that's a reason for us to be aware of this, and then as we're going to talk about a little bit later, the things that we can do to try to prevent it as well. This is something from actually a publication from Archibald from a couple years ago in 2013 that I thought was interesting. So it really showed the stats from the United States and then in Georgia, and then also Thomas County. So you can see that in our county alone, our rates of obesity mirror essentially what that is, and the national average is about 35%. And as you can see, there's been a stepwise increase, 2011, 2012, 2013. So definitely gives us pause and encourages, hey, we need to do something about this. We need to look at the causes of this. We need to figure out why our patients are continuing to gain weight, and so that we can try to prevent some of these links, including hypertension and heart disease, going forward. When we think about high blood pressure, there's a direct link to that, and I'm going to show you that in just a second, but we define high blood pressure or hypertension a couple different ways. You may have seen some of these numbers whenever you talk to your doctor in their offices. So normal blood pressure is a top number or systolic blood pressure of less than 120, or a bottom number or diastolic blood pressure of less than 80. As that begins to climb, 120 to 130, we get into a pre-hypertensive range, and then also that diastolic 80 to 89. Now, patients that have a blood pressure, on average, that the top number is greater than 140 is considered hypertension, and the bottom number less than 90. And as I said, there's a direct association with being overweight or obese with hypertension in our society, and in fact, about almost half, or 43% of patients that are obese have a diagnosis of hypertension as well. And it's not just patients that are obese that have this, but even those that are in that overweight range, which is that 25 to 30 range, we see also a large percent of them have high blood pressure. And if you look at folks that have normal weight between 20 and 25, that rate is about 15%. So there's a steady incline with folks that gain weight that we see that their blood pressures go up. And just like we looked at the graph before that showed that Georgia has a higher rate, has a pretty high rate, 30 to 35% of our population is obese, you can see that over the years from 1990 all the way to 2015, this line demonstrates we've also seen a steady increase of patients with high blood pressure as well. So those numbers tend to mirror each other going forward. So why do we care about high blood pressure? Well, high blood pressure affects multiple organ systems. And this is just a quick picture to try to depict this. So it affects small blood vessels first. And those blood vessels are oftentimes found in our eyes, found in our kidneys. And so we're going to talk a little bit about that tonight. And it also affects those small blood vessels that supply blood to our brain. And so that's why when you have high blood pressure, it puts you at risk for strokes, puts you at risk for cardiac disease, those small blood vessels that supply blood flow to the heart muscle. And again, kidney disease as well, those small blood vessels. So that's why when you're talking to your physician about your weight or about blood pressure, these are the reasons why we as physicians are working really hard to try to reduce blood pressures, because we know that if we can reduce those numbers, hopefully we can reduce the risk that you or your friends or your neighbors are going to have these complications such as strokes or heart disease. So there's several complex connections between obesity and hypertension. We know that it increases some things like insulin. So folks that are overweight or obese, they have higher levels of insulin. Another hormone called leptin. There's also a system in the kidney that is affected, and many others. All of those things, though, in some way or shape or form, actually increase the amount of salt retention that our bodies have at the level of the kidney. And as a result of that, it increases our blood pressure. So that's why whenever you're seeing your physician for high blood pressure, oftentimes our approach to managing high blood pressure in patients that are overweight or obese includes things like diuretics that actually help regulate some of that salt concentration within your body. And also, it's why oftentimes folks that are obese as well as that have high blood pressure, reducing the amount of salt intake in their food can oftentimes have pretty dramatic effects in their blood pressure. The other connection that I wanted to speak about was just about heart disease, and that includes both stroke as well as heart failure. And this is a stat that folks that have obesity and high blood pressure have almost a threefold increased risk of heart disease. We see, again, there's a graded incline with high blood pressure and the risk of heart disease, and it begins even at lower blood pressure such as 115. Here's another graph I wanted to show you that basically shows BMI, so the what we talked about before with this being obese patients here. If they have no high blood pressure, their risk of heart disease or dying of heart disease is about 14 to 15%. But if they have high blood pressure on top of that, it greatly increases those risks. So again, this is a reason why it's important for you as the general population and patients, but also us as physicians, to recognize these complications of obesity and then to act aggressively to try to treat them, to try to reduce these risks. So what can be done? So all this bad news that I'm telling you, so there are some things that can be done. So we know that with weight loss, if you can lose, this is on average, 2 to 3 pounds, so that's 1 kilogram, 2.2 pounds, that results in about 1 millimeter of mercury decrease in your blood pressure, which may not sound significant, but it is. It is. When we talk about each little bit lowering of blood pressure reduces your risk of heart disease, every little bit does matter. As much as 20 to 25 pounds can lower those numbers by about six points as well. So all that is very important. We do this with some weight-reducing diets. So there's a couple diets that are out there. One of these is called a DASH diet, dietary approaches to stop hypertension. This is a low sodium diet, low salt diet. Other common diets that you may see out there that have been shown to help reduce hypertension as well as help folks lose weight is this Mediterranean diet. And those diets have a lot of things that you're eating right now. So vegetables, it has a lot of, lettuce, tomatoes, it's got fruits, it's got things that you get on the outside of the grocery store, not on the inside of the grocery store. So also these low salt diets. So we know that by reducing salt, we can reduce hypertension. And also we know that it can help reduce stroke as well as heart attacks. And the last thing is physical activity. And we know that it doesn't have to be dramatic physical activity, but any amount of physical activity such as walking, jogging, cycling can reduce blood pressure as well as help reduce weight loss, produce weight loss as well. And so even without weight loss, aerobic exercises such as these things I'm mentioning can pay big dividends when it comes to reducing your blood pressure. And then, so just some recommendations as far as exercise. So the average, or what's recommended for exercise is 150 minutes per week. So that's doesn't have to be at one time. It can be broken up 10 minutes here, 20 minutes here, 30 minutes there. And it can be something as simple as brisk walking. And again, these can have dramatic effects on both your weight as well as reducing your risk of heart disease and strokes. And again, as far as calorie restriction, something I wanted to show is that, when folks are trying to have a diet that's going to result in not only weight loss but also reduction in their blood pressure, it's recommended they try to reduce that calorie by 500 to 750. And so you can see there just some of the average caloric intakes that might be goals for you as you consider a diet in the future. So again, I hope that you can kind of see the relationship between obesity and hypertension and heart disease, and give you an idea about why we as physicians are really working hard to try to reduce those things, reduce those risk factors, to try to reduce the chance that patients will develop heart disease or hypertension or strokes in the future. So, all right. I'm going to give way to Dr. Crenshaw.
Good evening. Thank you, Dr. Hatfield, for a phenomenal talk and introduction to obesity. My name is Daryl Crenshaw. Good evening. It's indeed a pleasure and blessing to be able to stand here tonight and present to you the associations of obesity and kidney disease. The objectives of my talk for the next few minutes would be, number one, to discuss the associations of obesity and kidney disease. Number two, discuss the causes of kidney disease. Number three, discuss the diagnoses of kidney disease. And lastly, discuss the treatment of obesity and kidney disease. As Dr. Hatfield elaborated, more than 1/3 of U.S. citizens have obesity. That's roughly about 37% of all United States citizens. Non-Hispanic blacks or African Americans have the highest rate of obesity at 48%, followed by Hispanics and non-Hispanic whites as well as non-Hispanic Asians. So in the African American population as a whole, almost half of African Americans are considered obese. That's tremendous. Also, obesity has the highest degree in middle-aged adults between the ages of 40 and 59. Second are older adults older than 60. And then last, younger adults have the less degree of obesity in the United States. And as Dr. Hatfield elaborated here, when you look at obesity in the U.S., you see here that the highest degree of obesity resides in the Southeast. That's in Mississippi, Alabama, Louisiana, and Georgia. And so when you look at Georgia, their rate is approximately 30%. Now let's look at kidney disease facts. The kidney is an organ that filters waste products from the blood. It regulates blood pressure, fluid removal, and red blood cell production. 10% of the population worldwide is affected by chronic kidney disease, or CKD. You may hear that terminology at times. And this includes about 26 million Americans. Kidney disease increases in individuals after the age of 50, and it's most common in adults after the age of 70. Early in the illness, most people are not aware that they have early kidney damage. So this is very important because oftentimes when we see patients in the office, and once we've diagnosed them with kidney disease, oftentimes it's at the later stage. And that's why it's imperative that if you have a family history of kidney disease, or even if you suspect kidney disease, as we'll elaborate in a second, you have to be very cognizant that you may not see signs until the later stages of kidney disease. And then lastly, kidney disease with function of less than 15% is classified as end-stage kidney disease. You may hear the term end-stage renal disease or ESRD. And at this juncture, more oftentimes than not, dialysis is required for the assistance of removing waste products and fluid from the body. And let's look at kidney disease. Likewise, with obesity, we see here that the highest prevalence or the highest degree of kidney disease resides in the southeastern United States. And so when you look at the kidney disease in conjunction with obesity and kidney disease, we see here that there's a strong connection in the southeast. And so we have to ask ourselves, well, what is the connection between obesity and kidney disease? Well, that connection is what's called the metabolic syndrome. And so ultimately, obesity leads to the metabolic syndrome, which comprises these components: central obesity, fatty triglycerides or high triglycerides, low HDL or a low good cholesterol. You can have high blood pressure and fasting blood glucose. And as Dr. Hatfield mentioned, men and women are different in the central obesity department, where men have a waist circumference of greater than 40 inches. That classifies them as possibly having metabolic syndrome. And in women, if the waist circumference is greater than 35 inches, that puts them in a category of possibly having metabolic syndrome. And you have to have 3 out of these 5 components. Now, when you look at the body habitus of individuals with metabolic syndrome, men typically have the apple-shaped body, meaning that the majority of their obesity resides in their core. As opposed to women, they have the pear-shaped body, which means most of their weight and their obesity is in their hips and thighs. So ultimately, when you have metabolic syndrome, this causes severe inflammation, okay? And when you get inflammation, this leads to consequences such as insulin resistance, ultimately leading to diabetes. You get lipid accumulation, you get atherosclerosis, or you get plaque in the blood vessel wall, you get further inflammation and stress, and ultimately you get more fat accumulation. And you see here in this diagram, here highlighted in this yellow box, these are all hormones and inflammatory markers that when they are ignited, they cause brain activity damage. They can also cause muscle insulin resistance, ultimately leading to diabetes. Also in the liver, you can get insulin resistance leading to diabetes. Again, you can get atherosclerotic disease where you get plaque formation in the vessel wall. And then you get also further stress and inflammation, ultimately leading to more fat production. These are fat cells, okay? And when you get this, ultimately, over periods of time, when you get increased inflammation, these are all risk factors for kidney disease. So let's look at some of the major factors for kidney disease. This includes diabetes, high blood pressure or hypertension, vascular disease, kidney stones, kidney cancer, and the use or increased use of nonsteroidal anti-inflammatory drugs. So let's look at diabetic kidney disease. Diabetes is the most common cause of kidney disease worldwide. Diabetes also involves excess blood glucose, which causes damage to the kidney blood vessels. You can also get damaged blood vessels that prevents waste from exiting the body, which leads to weight gain, swelling, and protein leakage. And then ultimately, you can get nerve damage from diabetes, which can prevent the bladder from emptying, which can cause damage to the kidney and increase the body or the individual having urinary tract infections. And so here, this is just a schematic. This is the kidney, and this structure here is what's called the glomerulus. This is the filtration system of the kidney. These are blood vessels microscopically that involve filtering urine from the body. And you can see here, this is a normal glomerulus, and you can see here highlighted with these yellow spikes, these are abnormal glomeruli or abnormal filtration systems, which ultimately lead to protein leakage in the body. So one of the early markers for kidney damage is when you see protein leakage in the urine. Let's look at hypertension kidney disease. Hypertension is the second leading cause of kidney disease. Remember, diabetes is number 1. Hypertension causes damage to the blood vessels and filters the glomerulus, which are these structures here of the kidneys. You can get damage to the kidneys, which make it difficult to remove waste and fluid from the body. Again, you can see protein leakage, you can see fluid retention, and you can ultimately have decreased urine output as a result of hypertension kidney disease. So here, you can see this is a normal kidney, okay? These structures here are the glomerulus. These are the filters, okay, that reside in the kidney. As you compare these to these are damaged, they are scarred, they are obliterated, and this is a result of hypertension, Okay, so when hypertension occurs, you get significant scarring to the kidneys. That's one of the major consequences of having hypertensive kidney disease. Let's look at kidney vascular disease effects. Given the significant lipid accumulation and inflammation secondary to obesity, one can develop atherosclerotic plaque, which you can see right here. Okay? You can get scarring of the kidney, which you can appreciate around the rim of the kidney or the outer aspect of the kidney. You can get total blockage of the blood vessels, and we call that infarction. You can see that highlighted by these little white spots here. You can also get fat accumulation, okay? All these are consequences of obesity. And then lastly, you can also get microscopic bleeding or hemorrhage. Let's look at kidney stones. Okay, kidney stones occur oftentimes in patients who are obese. Well, what's a kidney stone? Kidney stone is a hard mass that's developed from crystals that separate from the urine. Kidney stones build up on the inner surfaces of the kidney. You can see here, this is a kidney that's been filleted open, and you can appreciate the kidney stone there. Kidney stones can also lead to long-term kidney damage and infections of the kidney. Risk factors for kidney stones include low water intake and excessive sodium as well as red meat intake. And likewise, kidney stones are more common in the southeastern United States. Okay, and you can see here highlighted in yellow, again, this is the southeast. And we call this, around the country, they call this the stone belt. Okay, and the reason why is because the soil is laden with calcium. It's just rich in calcium. And also in this area of the country, because of the climate, we don't drink enough water. The major risk factor for kidney stones for any individual is that they don't drink enough water. So oftentimes, I have to tell my rural patients, particularly if they drink well water, it's often very common that when I see patients in the office who have kidney stones, I have to ask them the question, do they drink well water? Because it's laden with calcium. Have you ever noticed when you go in your shower, I've never noticed this, I came to Thomasville, you go in your shower and you see that lime deposition in your shower? That's calcium, okay? That same calcium that's in the shower head is forming in your kidney. That's a calcium deposit, and that's just because our water and our soil is laden with calcium. Let's look at kidney cancer, okay? Renal cell carcinoma is the official term. 273,000 cases are diagnosed each year. The highest degrees are in the Western world, and that's because of the degree of obesity in the Western world, meaning the United States. We see a higher degree of kidney cancer over here as well. In the United States, there were 64,000 new cases and approximately 14,000 deaths. It's slightly more common in males between the ages of 50 and 70. The diagnosis in the United States is increasing every year at about 2%. And that's because now we have more diagnostic modalities to pick up kidney cancer or renal cell carcinoma. And working with colleagues such as Dr. May, it has helped us to be able to identify kidney cancer in a more readily fashion. And when you have kidney cancer, the primary treatments include kidney removal, we call it a nephrectomy, as well as chemotherapy. And there's some other tests and ways you can treat kidney cancer too, such as ablative techniques and so on. Now let's look at the use of nonsteroidal anti-inflammatory drugs. When patients are obese, this increases their risk for generalized joint pain and inflammation. And as a consequence, they use these medicines, nonsteroidal anti-inflammatory drugs. They go and get them over the counter. But people have to recognize that these medications can increase the risk for kidney damage if they're taken too often. And these are those medications: Advil, Motrin, Aleve, Indocin, Celebrex, Mobic, Vioxx, Goody powders, BCs, Stanvax. How many of y'all ever take those medicines? All right, I see a few hands. Keep in mind that if you are taking those medicines, you have to be sure that your kidney function is intact, and that's why it's so important that you get your kidney function checked, and we'll talk about that in a second. So what are some signs of kidney disease? First sign you can see is change in the urine. You can see blood in the urine, you can see protein in the urine, and this is urine that's in the toilet, and you can see it has this pinkish blood, red tinge urine formation you can see here. You can appreciate that. If you see that, that may be an indicator that there is kidney involvement or kidney damage that may be occurring in you. You can also see here, can you appreciate these little bubbles? Okay. Sometimes when you see foam in the urine, it has this foamy texture like here. This means that there is protein. Okay, now obviously most of us when we pee, we all have a little bubble in our urine. So but don't get overzealous. But you have to keep in mind that if you see it and it foams like the foam on the beer commercials, you know, when you see that foam, if you ever see that and you have any risk or concerns for kidney disease, think about this. You can also have fatigue. You can also have itching. You can also have nausea and vomiting. You can get short of breath. You can have easy bleeding or bruising. You can get back pain, or not in the middle part of the back oftentimes. That's more musculoskeletal. You can also get swelling or puffiness, as you can appreciate here. And also appreciate here, you can see here, this is what we call pitting edema. You can see here the little pits, okay? If you see that, be concerned about kidney disease. Now, obviously, there are other sources for this, such as heart disease, congestive heart failure, or liver disease, but you have to be concerned about kidney disease. You can also get high blood pressure, as Dr. Hatfield mentioned, and you can get anemia, okay? The kidney has a great responsibility in making blood, okay? There's a hormone in the kidney, it's called erythropoietin, and what happens is that when the kidney is healthy, this hormone is produced, and essentially it goes to the bone marrow and helps produce bone. When the kidneys are not working, that hormone is less in function, and as a result, patients can develop anemia. Now let's look at testing. Okay, oftentimes I like to get urine samples because I want to look for blood, protein, crystals, stones, infection. I also want to get blood tests because I want to check a creatinine level. Okay, I want to check a BUN or blood urea nitrogen. I want to look at the glucose and cholesterol because I want to see if they're fitting the criteria for metabolic syndrome. I want to check a hemoglobin level. I also want to get diagnostic imaging, okay? And the cornerstone test we like to get is what's called the renal ultrasound. This is a renal ultrasound, all right? And what I'm looking at when I see this, I'm looking at this structure here. This is the kidney, okay? But what's more impressive is this circular structure here. This is a cyst. This is a huge kidney cyst, okay? And the wonderful thing about the renal ultrasound is, number one, it's non-invasive. Number two, I can look for kidney stones. I can check for masses. I can see if the kidneys are dilated. I can see if there's any abnormality regarding scarring of the kidney. The ultrasound can give us a lot of information in a non-invasive fashion, okay? We also like to get CAT scans or CT scanning and MRI. And then ultimately, there are times when we need to have a sample of the kidney tissue for a confirmatory diagnosis, and we do that through a renal biopsy. Now, prevention of kidney disease. Drink lots of water. Use 8 to 12 ounces of water up to 8 times a day. And in my kidney stone patients, I recommend even higher than that. I recommend up to about maybe 3 liters, okay? It's well known and documented that if you have a kidney stone and you don't comply with drinking enough water, there's a high chance you'll have another kidney stone within 7 years, okay? And this is a fact. Ever since in the last 20 years of being in medicine, I've asked all of my female patients if they've ever had a kidney stone, what would they rather have, another baby or a kidney stone? Every one of them said they'd rather have another baby. Kidney stones are extremely, extremely painful. Diet, exercise, and weight loss. I recommend that if you can, lose about 10% within a 1-year period. I also recommend low intake of salt and fat. Maintain a healthy, balanced diet, including fruits and vegetables. Fruits are very, very good for preventing kidney stones, especially citrus fruits. Okay, so if somebody has kidney stones, I often recommend to take a lime or take a lemon or take even an orange and squeeze it in your water, okay, because it has citrus, okay, or citrate. And citrate is known to really dissolve kidney stones. It can prevent kidney stones. I also recommend blood pressures. The goal guidelines say less than 130 over 80. Dr. Hatfield showed an optimum of 120 over 80. I think that's fantastic. But it's been shown if you can keep it less than 130 over 80, you reduce your risk of further kidney damage later on. You can also keep adequate blood glucose control, hemoglobin A1C of less than 7%. Again, if all be possible, and if you definitely have any pre-existing kidney disease, I recommend to avoid all nonsteroidal agents, okay? And also avoid tobacco products. Well, the question comes up was, well, I have arthritis, I can't take a leave. Doctor, what can I take? My next answer is Tylenol, okay? With the exception that if you have liver damage or liver disease, then obviously Tylenol, you have to watch for that. And then lastly, be aware of symptoms of kidney disease and report to your physician any concerns. And the reason why is because there are medications that have been proven to protect the kidneys. Okay, a class of medicines are called angiotensin converting enzyme inhibitors, or ACE inhibitors, or angiotensin ARBs, angiotensin receptor blockers, ARBs. Those are medicines that can definitely protect the kidneys and prevent further kidney damage. Okay, so keep calm and love your kidneys. Thank you.
I'm Dr. Amanda May. Thank you all for coming this evening. And I have a few things to say that sound very similar to what my colleagues have already talked about. I'll try not to repeat as much of the statistical data that they've talked about, but rather talk a little bit more about how this impacts cancer care. I don't say any of this to belittle anything my colleagues have said, but a lot of people will tell me, well, high blood pressure, you can live with that. There's medicine you can take. And your kidney disease, you know, you've got good doctors like Dr. Crenshaw that can keep what kidney function you've got going, even if you've had some damage. But the patients that come to me when they've heard the C word and they have cancer, you know, everybody just thinks they're going to die the minute they walk in my office. And fortunately, the thing I can say good about cancer is many of our cancers are becoming chronic diseases. That doesn't mean I'd still wouldn't like to eradicate them rather than having that chronic disease on someone's list. So that's the good side of that. But some things about obesity that we know are affecting cancer. And I just want to say, I'm going to make a couple of statements that are, you know, they are supported by data, but they are a little kind of scary sounding. One of those is that overeating may be the largest avoidable cause of cancer in non-smokers. You know, when you think you want to go back for that second plate, you know, when you think you want to go eat somewhere or eat a dessert or do something extra that, you know, you kind of think, maybe I shouldn't, but oh, it's so good, I'm going to do it anyway. That's kind of a big thing to think about, that if there's anything other than not smoking you could do for yourself to avoid a cancer diagnosis, it would be not to overeat. And I know that sounds really simple, but it's not. Because if it was, we wouldn't have these problems, and we all wouldn't be here giving this talk tonight. So overweight and obese issues now account for about 1 in 7 cancer deaths in men and 1 in 5 cancer deaths for women. This is because of obesity being related to increased risk of cancers. It has to do with obesity causing difficulty in how we treat cancers. Most of our chemotherapies that we use do involve weight-based dosing. So we run into issues with folks who are overweight or obese getting higher doses of medicines. They may have more side effects. They may be less tolerant of the medications. Or in trying to reduce those side effects, we may actually be underdosing patients and not giving them the amount of treatment they need to actually treat their cancer. And a lot of our drugs, the way they work, have to do, I'm going to get into the science of things now, the volume of distribution, where how the drugs are fed throughout your body. Well, when you have changed how your blood vessels work and the size of your body, that may impact about that medicine getting to where it needs to go to do what it needs to do. You know, and then we also know that, like I said, with higher doses of medications, higher risk of side effects, it decreases quality of life and can decrease patient compliance or willingness to undergo what can be potentially curative treatments. And also, with patients who are overweight and obese, we know they have higher risks with surgical interventions, slower rates of healing, and that sort of thing, which of course, surgeries still play a big role in how we treat cancer as well. So that's an important thing to think of. And like I said, those are kind of some scary numbers. And we've seen, you know, from my other colleagues who presented that about 1/3 of the population, or a little more than that, qualifies as obese with that BMI over 30. Here's the other scary number. When we add BMI down to 30, which is just those folks that hit the overweight category, that accounts for 2/3 of our population. And your risk starts at that BMI of 25 and above, not just at 30 and above for some cancers. So kind of some big numbers. There's genetic and environmental factors with obesity and cancer. You know, obviously it's not, you know, if it was one easy thing to fix, we'd probably have come up with a pill for that, and this wouldn't, again, be a conversation we'd all be having. So the risk factors that involve with this are also in age. You know, we do see obesity across all age groups, which has already been alluded to tonight, but the most common age group for obesity is between ages 45 and 64. And that's also when most cancer risk peaks. for most types of cancer, is when you're most likely to be diagnosed with cancer. Some cancers peak in younger ages, like a Hodgkin's lymphoma, that peak is in the 20s, so that doesn't fit in this group, and that's not one of those cancers that's linked to obesity. However, other cancers like breast cancer and colon cancer, those peaks are between the ages of 45 and 65, just like this is. So those are things to keep in mind and why we do have this connection between obesity and cancer. Actually, weight gain and obesity account for, we estimate now, about 20% of all cancer cases. So some big numbers. And to kind of break down, we've already talked about what qualifies as obesity, waist circumference, those sort of things. My other colleagues have already talked about that, so I'm not going to really review that again. But just to kind of go through some different types of cancers, because it's not just one or two cancers. I mean, there's some that are higher risk that we have better data for, but there's actually quite a list of cancers that are involved with patients and obesity. So endometrial cancers and esophageal cancers have about a similar risk as far as with obese patients. Again, that's your BMI of greater than 30, of about 2 to 4 times the average population of non-obese patients. The way they figure these numbers, this isn't arbitrary or they just guessed at some numbers. They do cohort studies where they look at folks with BMIs above and BMIs below and follow these folks for years. And so that we can kind of obtain some of this data and see what's changing and what's different of this patient to that patient. And we know that there are probably activities and things folks do, whether they're obese or not, and that may also play a role in this. So we can't say that it's 100% just due to this, but based on our statistics, this is where we're at, the real numbers we have that I can talk to folks about. And the risks for endometrial cancer often have to do with increased estrogen production, because fat cells, actually we make estrogen, men and women make estrogen, and you make that through a pathway that occurs in fat cells. And that's normal, and we're supposed to do that, because it does serve a role in many different pathways and things we do about laying down memory and keeping our bones strong and our hearts healthy and all of that sort of thing. So we have to have some, but when you have too much, the system gets disordered and doesn't work as well as it should. So that does increase risk pretty significantly. And this risk is independent of hormone use. Because I'll get people that say, well, but maybe they took hormones, or maybe they looked at this independent of hormone use. And with esophageal cancers, the most common is the adenocarcinoma type of esophageal cancers. There's a couple of different kinds, because there's different types of cells that line your esophagus from your mouth down to your stomach. The one that's increased risk is the adenocarcinoma, which typically exists at the lower part of the esophagus, just at the top part of the stomach. Because folks who are overweight and obese tend to have a higher risk of reflux. They tend to more frequently have hiatal hernias, and that increased acid irritates the lower part of the esophagus, and that's one of the risk factors for cancer. So we believe that's probably part of the increase in risk, not just the obesity itself, but it doesn't account for all of it. So in keeping with that, the next things down are a 2 times the normal population increased risk for things like gastric cancer and liver cancer. And the way these cancers work has to do with again, the acid production. The most common gastric cancers in obese patients are in the upper part of the stomach versus the lower part of the stomach. And in liver cancers, it often has to do with what we call fatty infiltration of the liver. When you're overweight or obese, your body puts that fat all sorts of places, not just in your, in your stomach where you can see it, or your legs or your arms. It also hides it around your organs, which we've seen in the kidneys as well. Well, one of the common places for that fat to end up is in your liver. That does cause liver dysfunction. And when the liver is not functioning correctly, or certainly inflamed, that's what leads to tumor production and the increased risk in folks who are obese. There's also about a 2-fold increase in kidney cancers, which we already talked about, so I'm not really going to belabor that point any further. I've got plenty of others to talk about. The other risk is pancreatic cancer. There's about a 1.5% risk, or 1.5 times the normal risk of having a pancreatic cancer. And these are the cancers that scare me the most because they're the ones we are least capable of treating at this point. Despite our new drugs and better surgeries and earlier detection techniques, this is still one of the very scary cancers that's very, very hard to treat, that many people do not survive. And certainly if there's anything I can find to help somebody reduce their risk of this particular cancer, that's pretty high on the list because it's the best thing we can do right now is prevent it rather than trying to treat it. Those studies are ongoing, of course. Other cancers, there's percentage risk increase over kind of a baseline. It's not really as much as a 2 or 4 times risk. And those would be things like colorectal cancer, which is about a 30% increased risk for those folks who are overweight and obese. It's actually a greater risk in men than it is in women. So obese men are more likely to have a higher risk of colorectal cancer than obese women, but it's still increased compared to those folks who are not obese. Gallbladder cancer is another, where overweight even, just in that 25 to 30 category, you have about a 20% risk of increase of gallbladder cancer. When you get into the obese category, it's as high as 60%. And the reasons behind that, again, cancer has to do with inflammation and DNA damage and that sort of thing. So what happens in those situations is you have a higher risk of gallstones, and more gallstone production is more inflammation, more irritation of the gallbladder, and then that ultimately leads to that higher risk of cancer. So, and one of the other types of cancers that's not real common but does exist, multiple myeloma, is actually what we call a liquid tumor, because it's not often seen as a solid type of cancer, until it's in its later stages. We see it in the bloodstream in our bone marrow. But there is about a 10 to 20% risk in obese patients for this. And unfortunately, too, it's a higher risk disease amongst the African American population. So with higher rates of obesity, already a predisposing condition there. And that disease is, it's not curable. We do have good drugs that treat it. It's a more chronic disease than it used to be. But again, it's not a curable disease, and it can affect your kidney function. It can affect your bones. So, that's an important thing, that if you can reduce your risk for that, it is very good to do. And breast cancer and ovarian cancer are probably the big things that I get asked about the most. And those do have increased risk with increasing the BMI or body mass index, with obviously the obese patients having the higher risk. But it actually, with every point of BMI that you're above normal, your risk is about 10% increased for ovarian cancer. And then with breast cancer, it's not quite that, but it's close. It's for every 5 units up, it's about a 10 to 12% increased risk. And this is, again, with breast, like I talked about with the endometrial or the uterine cancers, this is independent of hormones. So they looked at people who were not taking hormonal therapy, because that changes the game. That's a whole risk factor in and of itself. So in the truly obese patients, the BMIs of greater than 30, it's a 20 to 40% increased risk for breast cancer. And those are in postmenopausal women. Interestingly, there's a little less risk of certain types of breast cancer in premenopausal women who are obese. But unfortunately, what they then end up with is the non-hormone receptor positive cancers, which are, again, harder to treat and we have more limited resources for. There's even an increased risk for meningiomas, which are technically a benign type of tumor, not truly a cancer. But these grow in the brain, which, even though they're benign, if they grow in just the wrong place at the wrong time, can have some significant side effects and problems, and are not always operable, even though that they generally are readily removed. But there's a 50% increase in obese patients to develop meningiomas. So there's less statistics, but we know there's some correlation with even things like thyroid cancer, prostate cancer, melanomas, leukemias, and lymphomas, and obesity, that there is a somewhat higher risk. There aren't enough numbers out there for me to really tell you what kind of percentages there are with those, but we do know that that's there. And again, we know that all these cancers have to do with chronic low levels of inflammation that exist, that are higher in folks who are obese than are not. and I talked about, like the reflux and esophageal problems and, the fat-producing estrogen, and there's all these sort of things. And there's actually a substance that's produced in fat cells. There's two substances that can be produced, and when you have one substance gets higher because you have more fat, the other substance goes down. And what these substances do is one promotes growth and one inhibits growth. So even though that seems like, well, why would that be so bad? Well, once you've developed a cancer, if you have that substance that's a growth promoter, you're promoting a growth of a cancer, and you're depressing that level of the growth regulator that would normally stop growth. So, and again, some of that's more scientific theory than we actually have data to show, to be able to say, for sure this is the way this works. That's something that we're continuing to look into as a target, a way that we could maybe help stop growth of cancers and worsening disease once they have occurred. But again, what we're here to talk about tonight is how can we prevent this? What can we do different? How can we change things? Just some other numbers too to kind of throw out there. In 2012, they attributed approximately 28,000 cancers in males were attributable to obesity alone, 72,000 in females. So it's the female cancers are at a higher level number of diagnoses than cancers we see in males attributable to obesity, and as those death rates were higher too that I mentioned before. In the U.S. in 2016, we have the highest percentage worldwide of cancer attributable to obesity, and that's in colorectal, pancreatic, and postmenopausal breast cancer. So that's a little scary. For all we have in healthcare, for all the resources we have, that we have that highest, and that's looking at other industrialized nations too, not comparing to, Africa and some other places, countries that don't have all the resources we have. This is comparing us to other countries that have our same resources, that we have a higher cancer attributable to obesity than other countries. So we've got a little bit of work to do. And like I said, the other things that obesity can play a role in, not just in, our diagnosing of cancer, but how our patients do. And once I have a patient, I want the best for them. I want them to do well. I want them to get through their treatment. I want to do what I can to help keep their cancer away, cure their cancer, help them not get another cancer, because obviously patients who've had one cancer are at risk, either from the treatment, unfortunately, that I've had to give them, or just because of those risk factors that existed for their cancer in the first place. So we do advocate for weight loss, and unfortunately there's not a lot of data to say that that helps people. We have just intuitively truly believe that. There are studies that prove in survivorship, so those are patients who've been diagnosed and treated and their cancers are controlled, or they have what we call no evidence of disease, that there is a decreased quality of life for those folks who are obese. They have an increased risk of recurrence and an increased risk of progression of any existing disease. And their survival in general is decreased compared to the matched cohorts. Such as in breast cancer, obese patients have a higher risk of lymphedema, which is swelling of the arm after they've had their surgery for their breast cancer. They have an increased risk of incontinence when they've had surgery for prostate cancer. And they're also at increased risk of local recurrence with rectal cancers. They have an increased death rate from those who get diagnosed with multiple myeloma. And there's actually an up to a 50% increase in the death rate in multiple myeloma for those who are what we call morbidly obese, who have a BMI of greater than 40. We've got a lot of current studies that are ongoing looking for the benefits of weight loss specifically in cancer. We know with kidney disease, with heart disease, we definitely have numbers that we can show people. With cancer, this is sort of a different place we've gone to. We've always been so focused on treatment. We're now trying to go back the other way and see what else can we do to prevent. Because there are those things like pancreatic cancer that we just can't seem to find the cure for, or the best treatment for. So maybe the better answer is to try to figure out a way to make it not happen from the front end. So those are the kinds of studies that are ongoing. There is evidence that exists now in both breast and colon cancer that we have improved outcomes, so patients do better, they feel better, they have a better quality of life overall, they're less likely to have recurrent or new disease if they increase their physical activity after their diagnosis. So, that's kind of the first really hard and fast data that we have to say that, doing a specific activity after you've had this diagnosis that can help you be better, do better, live better, and decrease your risk for having recurrent or new cancers. And increasing your physical activity, as pointed out by my colleagues, doesn't mean you have to go to the gym and lift weights for 3 hours a day. It's a 30-minute walk once a day. It's having one of these little things on your arm and making sure you get 10,000 steps in a day, which seems like a lot, but if you kind of keep at it, it's not so bad. And it really does change. Your weight might not change a whole lot, but it changes how you feel, and it changes how your clothes fit, and it does make things a little bit different. If you even just take those little steps, a few of them, but little steps, as it were. And one of the things we do for our patients in the Cancer Center, which has been really, I think, a good thing for our patients when they're diagnosed with cancer, we have a relationship with the Y here in town, something called the HOPE program, where we have patients that participate in exercise programs because we want those patients to get active. And it's about getting active where they are, not, like I said, not turning somebody into that lives at the gym for 3 or 4 hours a day, because that's not practical for most people. But it's getting people where they are and just getting them anyway healthier than they were when we started. So, thank you for your time.
Is it true that when your diabetes go up, it affects every part of your body or some part? Talk to me.
Yeah, absolutely. If I had my choice of one illness to try to curtail or try to minimize, it would be diabetes. As Dr. Hatfield showed you the image of all of the organ systems that are affected by diabetes. I think, yes, you're absolutely right.
So it affects every part?
Essentially every part. That's right. That's right.
Anybody else have a question? One of the questions asked on here was, why would someone's blood pressure still be high even while on medication? So, I guess Dr. Hatfield doesn't take that.
So there's, go ahead.
Yeah.
So there's I guess a multitude of reasons why that could be. Either the medications may not be the appropriate dose, maybe they're going to require a higher dose than what they're currently on, or people will respond to different medications in different ways. So we have a host of different blood pressure medications that are effective, but some may be effective in different people, whether it's their race or whatever it may be. So that would be the first thing. And then, again, I talked a little bit about salt intake. That can play a big part as well. So medications is just one part of trying to reduce blood pressure. It often includes lifestyle things like salt, reducing salt intake as well as exercise.
Any other questions? Any other questions?
About these NSAIDs, my doctor told me not to take a leave anymore, and I don't take a leave anymore. But the last time I bought aspirin, it was labeled as an NSAID. What's up?
You're absolutely right. It is a nonsteroidal anti-inflammatory drug. That's exactly right. And that, sir, is probably the one medication I have in my practice. What I do is every patient that comes, I hand them a list of the no-no medications, and all those medicines are on there, and aspirin is on there. Now, what I recommend is, because obviously we know the benefits of aspirin in regards to stroke prevention and heart disease, I recommend, obviously, if you have to do an aspirin, 81 milligrams, okay, or a baby aspirin. If you have to do the 325, I don't object to that. That's the one non-steroidal that I will allow any individual to take.
That's a good thing, because Tylenol doesn't seem to help.
Okay. One last question here.
I love sweet tea. Is sweet tea bad on your kidney?
It's a good question. I'm from Alabama. So, it's a distinction between sweet tea and real tea. The answer to that is it can be bad, and this is why. 2 reasons. One is tea has caffeine, okay? And we know what caffeine does. Caffeine is just like a diuretic, okay? It gets rid of fluid. And so particularly individuals who just drink tea all the time, particularly sweet tea, all right? You have two effects going on. One is the excess sugar that's in the tea will allow you to pee off more than you really hold on to. And so in essence, you can dehydrate your kidneys just based on the sugar content. The caffeine does likewise, okay? So like a glass of sweet tea, about 8 to 12 ounces of sweet tea is literally like 20 milligrams of Lasix. How many of y'all take Lasix? It's a water tablet, okay? So when people are drinking sweet tea, they're literally getting excess water off. It's like a diuretic. The other thing tea has in it, it has oxalate, okay? And oxalate with tea can cause kidney stones. It's one of the biggest reasons people get kidney stones is because of a combination of calcium and oxalate. When you consume a lot of oxalate from tea, it increases your risk for kidney stones.
All right. I think that's going to be it. It's a little after 7 now. We're going to hold you too long. But let's give them another round of applause tonight.